Hi, I'm Justin, one of the pediatric radiation oncologists here in Vancouver, BC, Canada. Thank you for the opportunity to give this presentation on Ewing sarcoma. Before I proceed, I would just like to acknowledge the suffering and hardship that Ukraine as a nation and people are experiencing right now, and I send my condolences and prayers for peace. I would like to begin this talk by giving brief background on Ewing sarcoma and then proceed to general management approach, local control options, radiation simulation, target volume definitions, dose and fractionation, dose constraints, outcomes, and toxicity. Ewing sarcoma is one of the most common primary pediatric bone cancers with median diagnosis at age 14 to 15. They primarily occur in the diaphysis of the bone, and imaging features moth-eaten onion peel Codman's triangle on X-rays. The pathognomonic molecular fusion is EWSR1 Fly1 fusion, which occurs from translocation of chromosome 11 and 22. Local therapy can include surgery or radiation therapy, or both together, and the backbone chemotherapy consists of VDC, IE, every 2 weeks. Ewing sarcoma is radiosensitive, hence radiation plays a prominent role in management of this disease. As we can see, Ewing sarcoma occurs quite commonly along the axial bones. Often, they arise from ribs, spine, pelvis, or femur. I would like to start out with a case so that we can best illustrate management of Ewing sarcoma. 16-year-old female has several months of right leg pain with growing mass in the anterior pubic bone. Pelvic AP X-ray demonstrated destructive, lytic, moth-eaten appearances and changes in the right superior ramus. MRI of the pelvis was performed, which demonstrated this heterogeneous T2 hyperintense multilobulated mass sitting in the pelvis. Biopsy was performed and showed EWSR1 Fly1 fusion, classic for Ewing sarcoma. In terms of the general management approach, the most up-to-date protocol is AEWS 1031, which encourages induction chemotherapy with VDC, IE systemic agents every 2 weeks, and attempt at local control, ideally at around 12 weeks or 6 cycles of chemotherapy, and further consolidation with systemic therapy. As mentioned before, both surgery and radiotherapy can play a role in local management of Ewing sarcoma. The benefit of surgical resection is that it avoids late effects of radiotherapy, and based on surgical specimen, you can better prognosticate. However, the risk with surgery is that it may cause morbid functional deficits, and in cases of positive margins, they may require postoperative radiation therapy. Thus, the ideal candidate for surgical resection alone would be those who have smaller peripheral tumors in expendable bones such as extremity or ribs or clavicle. Those who could have resection with negative margin and those who had good response to neoadjuvant chemotherapy would be the ideal candidate. Radiation therapy alone as a local control modality is used as well. It avoids the morbidity of resection and able to treat unresectable lesions. However, some of the risks for radiation therapy is that it's associated with late effects and risk of second cancers down the line. So typical ideal candidate for radiotherapy alone approach would be those who have larger, more central unresectable tumors and any tumors that may potentially have positive surgical margin, or those who have had poor response to neoadjuvant chemotherapy. There's an evolving literature around combined radiation therapy and surgery approach for local management. The benefit potentially is that it might offer the best local control, but the side effect would be that it increases the morbidity compared to just using single modality. And neoadjuvant radiation therapy has been commonly used in Europe for those tumors that are at risk for having positive margin after resection, especially for pelvic Ewing sarcoma. Of course, we know that adjuvant radiotherapy is often used for residual tumors, intraoperative spill, and less than 90% necrosis after primary surgical resection. In terms of the local control rate in modern series, Ahmed et al. Published a Red Journal article in 2017 that analyzed about 1,000 patients in retrospective manner. And we could probably conclude that local failure rate is approximately 20% or less with either modality. In this study, multivariate analysis did demonstrate that pelvic site or radiation therapy alone were associated with worse local control rate. However, it is quite hard to extrapolate whether RT is truly inferior because there are selection biases, such as those who had RT had more central tumors, larger tumors, pelvic/vertebral body tumors, and there were more proportion of those who had RT alone in older studies in which chemotherapy agent as well as timing were inferior and likely also contributed to poor local control as well. The most recent publication on AEWS 1031 demonstrated that regardless of modality, local failure rate was less than 10%. And pelvic site did trend toward worse disease survival, but it was not statistically significant, although the study was not powered to detect difference. So given that pelvic Ewing's is particularly challenging, there have been some strategies that are being investigated currently. One of them is use of preoperative radiotherapy for all pelvic Ewing sarcoma, and some retrospectives suggest that there is improved local control with this combined modality, and in fact it has gained some popularity in many of the European nations. Another consideration is use of proton therapy to optimize local control. While there is a bias in these studies because proton therapy centers are often more experienced and have multidisciplinary team, um, proton therapy can potentially avoid dose compromise due to OAR and hence may improve local control for pelvic Ewings. And there's another recent randomized prospective study out of India that was published in Red Journal in 2022 that dose escalation to 70.2 gray may improve local control for unresectable Ewing sarcoma. In our case, patient tolerated 12 weeks of systemic therapy well, so after discussion, patient proceeded with definitive radiotherapy as she underwent 55.8 gray primary photon radiotherapy with VMAT. This is the dosing guideline from AEWS 0031 as well as 1031. And we can see that PTV1, which is pre-chemotherapy disease, should receive 45 gray, and PTV2, which represents post-chemotherapy or residual disease after systemic therapy, should get 10.8 gray boost for a total of 55.8 gray. In terms of radiation simulation, radon should always be present at CT simulation and mold room to assist with setup and immobilization and to assess the patient setup. One could consider both photons, VMAT, or protons as a treatment modality. We often use CT simulation with 2.5 millimeter slices, and we fuse the CT simulation with preoperative and postoperative T1 contrast and T2 MRI. Depending on the site of the tumor, we position them in a reproducible manner, but often they're in supine position with isolated limb from the body. For instance, if this is a femoral disease, we would try to spread the legs to make sure that contralateral leg is spared from any kind of integral radiation dose. Immobilization usually involves back lock for pelvis, and we ensure that joints are immobilized so that they are reproducible every time. And we mark scars with wire, and if close to the disease is close to the testes, we use clamshell for protection, and consideration should be given for dosimeter as well as sperm banking. This is the demonstration of radiation therapy volume. CTV1 should include pre-chemotherapy GTV with 1 centimeter margin and paired back for organ shifting into normal position. So in this case, they would include things like the bladder, the rectum, or the obturator muscles. This disease should receive 45 gray in 25 fractions. And the CTV2, which is the sequential boost phase, should include post-chemotherapy GTV with 1 centimeter margin, paired back for organ shifting into normal position. So this sequential boost should receive 10.8 gray in 6 fractions for final dose of 55.8 gray. Notice that for vertebral bodies, they usually recommend slightly lower dose at 50.4 gray to ensure that we minimize the risk of myelopathy. In terms of the relevant organs at risk, for this particular patient, they would include skin, bladder, rectum, ovaries, joint line, femoral head. Potential acute side effects may include fatigue, dermatitis, gastrointestinal, genitourinary side effects, or pain flare. Unfortunately, there can be numerous late side effects associated with radiation treatment, including skin changes such as hyperpigmentation, fibrosis, or atrophy, gastrointestinal side effects such as bowel pattern change, bowel obstruction, perforation, polyps, and bleeding, genitourinary late side effects such as urinary stricture, bladder injury, as well as others like chronic pelvic pain, vaginal stenosis, ovarian failure, infertility, growth discrepancy, osteoporosis, fragility, bone fracture, and secondary malignancy. These are some of the OAR dosing guidelines published on AEWS protocol, and for this patient, the relevant OARs would be bladder, rectum, and small bowel. However, I would encourage that we always try to use as low dose as possible to these organs at risk, as Quantec was not validated in pediatric population, and there is an ongoing effort to develop OAR dosing constraints for pediatric population called PENTAC. For our patient, she was essentially cured of her disease, and after 2 years, her MRI demonstrated no evidence of disease. Now, common scenario in Ewing sarcoma is that patients come with lung mets, and as many of us know, this still represents a curable condition, and long-term event-free survival is measured at approximately 20 to 40%. In terms of standard of care for lung mets, we would recommend consolidative whole lung irradiation after all cycles of chemotherapy, but there are potential other alternative options such as surgical resection or stereotactic radiation treatment. So the benefit of whole lung irradiation for pulmonary metastasis in Ewing sarcoma is that it can potentially improve overall survival and event-free survival and reduces lung recurrence by 50%. Paulson et al. Showed in his publication in JCO and Annals of Oncology in 1998 that whole lung irradiation improved event-free survival based on retrospective study and demonstrated that in multivariate analysis, those who had pulmonary mets only and received whole lung irradiation had improved event-free survival. So this is the most recent AWS protocol for pulmonary metastasis that mandate that these patients get bilateral whole lung radiation. However, surgical management of residual pulmonary tumors was allowed. While it did suggest that post-chemotherapy volume can receive boost, by far the majority of these patients who only present with lung metastasis do respond quite well to systemic therapy, and after all the cycles of consolidative chemotherapy, we often see no residual disease. So most often, I think what we will encounter is patients who are greater than 60 years old who may have lung mets, but after all cycles of chemotherapy have no residual disease, in which case we can usually get away with 15 gray in 10 fractions of whole lung irradiation after all cycles of chemotherapy. At our center, we routinely use VMAT for whole lung radiotherapy. In terms of whole lung radiation simulation, again, radon should be present at CT SEAM and mold room to assess setup. Modality include photons. It could be APPA style, IMRT, or VMAT. We also use simulation, CT scan with 2.5 millimeter slices, chin to below diaphragm, supine, arms by side, and head in a neutral position. And of course, we acquire 4D CT scan and make sure that if patient requires sedation for simulation, the patient is also sedated for the treatment of delivery to ensure reproducible breathing. This is an example of whole lung irradiation with APPA field. The CTB traditionally includes the bilateral lungs, mediastinum, and pleural recesses, and the field inferior border is around L1, L2, superior border is about 1 centimeter above the first rib, lateral field extends 1 centimeter beyond the lateral lungs, and you attempt to block the humeral heads. While this would be associated with minimal risk of geographical miss, in order to cover the pleural recess, the inferior edge irradiates unnecessary amount of abdomen, liver, and bowel. And of course, with this technique, you're not able to shield any of the heart structures. This is an example of VMAT plan for our patient. We prefer VMAT at our center because it can reduce dose to the heart, the breast, and abdominal organs in comparison to APPA style or 3D conformal radiotherapy. And we use ITV encompassing entire lung based on the 4D CT. The contouring guidelines are available in the Kala Purakal et al. Red Journal in 2020. The caveat with whole lung irradiation is that if a primary site requires radiotherapy and it is close to the lung, then rather than waiting for all cycles of chemotherapy to finish and then give whole lung irradiation, it is best to give whole lung radiation with primary site radiation therapy at the same time. For instance, this is an example of left seventh rib that required adjuvant radiotherapy after surgical resection due to microscopic positive margin. So, this adjuvant radiotherapy to the seventh rib was given at the same time as bilateral whole lung because this patient presented with lung metastasis. You can see why this could be very challenging if you only gave adjuvant radiation to the seventh rib and waited after completion of radiation systemic therapy to give the bilateral whole lung, because it would be incredibly difficult to match the fields or calculate the dose accurately and deliver safe dose of radiation to the lungs. So this patient decided to undergo whole lung radiation. Potential acute side effects can include fatigue, dermatitis, cough, esophagitis, pericarditis, and radiation pneumonitis. And late side effects can include breast hypoplasia, skin cosmetic changes, radiation-induced lung fibrosis, cardiac dysfunction, coronary artery disease, esophageal stricture, and secondary malignancy. At 1.5 years from the treatment, patient is free of disease. Thank you everyone for allowing me to give this presentation. It has been a real joy and pleasure to be able to share our experience and knowledge on Ewing sarcoma with my colleagues in Ukraine. And I hope to see you all someday in the future. And I would like to conclude this slide with a picture from our cancer center looking at our northern mountains. So thank you.